This evening, we're going to hear from a very special guest on her experiences in managing the virus in a large COVID-19 positive population, what preventive and treatment strategies have been adjusted in the last couple of weeks, and then some case-based discussions as well. So we do have a few housekeeping notes. If you are listening to this webinar, we encourage you to submit any questions you have, and we will try to answer as many of them as we can during the Q&A portion of this webinar. We'll actually be trying to kick off the Q&A portion around a reasonable tonight, around 8:40 or so, and we'll try to get as many of the questions in as possible. Also, to expand your video player to full screen, click on the icon on the lower right of the player, hit escape on your keyboard to revert back to the smaller player. So we have a distinguished panel of experts on today's presentation, and I'll ask each of them to introduce themselves and give their title and affiliation. Dr. Aggarwal.
Hi, everyone. I'm Charu Aggarwal. I'm the Leslie Heisler Assistant Professor of Medicine at the Abramson Cancer Center at University of Pennsylvania. It's so nice to be back here tonight.
Thank you. Dr. West?
Hi, folks. I'm Jack West. I'm an oncologist, actually associate clinical professor in medical oncology, focused in thoracic oncology at City of Hope Comprehensive Cancer Center in the Los Angeles area.
Thank you. Dr. Pennell?
Hi, everyone. My name is Nate Pennell. I'm a thoracic medical oncologist and an associate professor of medicine at the Cleveland Clinic, Tasca Cancer Institute in Cleveland, Ohio. Also the director of the lung cancer medical oncology program there.
Thank you. Dr. Liu?
Hello, my name is Stephen Liu. I'm an associate professor of medicine and director of thoracic oncology at Georgetown University in Washington, D.C.
Thank you. And last but not least, Dr. Farago.
Hi, I'm Anna Farago. I am a thoracic medical oncologist at Massachusetts General Hospital and assistant professor of medicine at Harvard Medical School.
Thank you, everyone. And Dr. Farago, thank you so much for being here with us tonight. We're very excited to have you here with us and hear some of your insight.
Thanks for having me.
Of course. So as mentioned, this is the 7th webinar in our planned series. So anything that's not covered during this discussion can certainly be raised in our next webcast. We do have a great deal of material to cover tonight, so let's begin. To start us off, I would like to provide just some very quick numbers on the current state of COVID-19. To date, the number of global confirmed COVID-19 cases are more than 4 million, with more than 287,000 deaths. Actually, I believe the WHO just very recently updated, so it's actually more than 294,000. The United States has over 1.3 million confirmed cases with 83,947 deaths. Meanwhile, we are all continuing to observe the social distancing guidelines that have been instilled upon us. There is much more challenging for this to follow for patients who have serious medical conditions that require urgent attention. Over the last several weeks, we have discussed how COVID-19 continues to impact so many aspects of our personal and professional lives, and especially how our experts manage lung cancer in their patients to preventive measures that they are taking in practice. Tonight, we're going to be diving into some more very important topics in this space. So with that, I would like to turn it toward our discussion with Dr. Farago. I know our panel has several questions for you, but first, would you be able to share some of your experiences on managing the COVID-19 pandemic at MGH and some of the experiences that you've had, especially having to work in the ICU?
Sure. So, as you know, Boston has been pretty hard hit by COVID. MGH is the largest hospital in New England and serves patients really across the northeastern United States. The hospital started seeing admissions of patients with COVID-19 in March and quickly restructured the whole inpatient services within the hospital to accommodate the anticipated flux of patients. So by mid-April, we reached our peak of COVID-19 cases, at least to date, which was over 300 patients at one time. And approximately 35 to 40% of these were ICU patients. To date, the hospital has now treated and discharged over 1,000 patients with COVID-19, and there have been, unfortunately, 144 COVID-positive deaths at MGH. So that's kind of our latest statistics. This obviously has impacted all of our practices tremendously. Starting with the outpatient setting, by mid-March, we were very quickly transitioning to a lot of virtual visits and minimizing patient visits into the clinic. Our thoracic group, which is staffed by 10 thoracic oncologists, really reduced down to 1 MD and 1 nurse practitioner on site each day, both to minimize the risk of us transmitting to each other, and also to really try to minimize the number of people interacting with any given patient on a given day. We've actually mostly maintained that model going forward, although we're now starting to ramp up a little bit more. So in parallel, while we were doing that within our small group, the hospital, of course, was developing protocols for managing outpatients with risk of COVID or possible COVID exposure or symptoms concerning for COVID. So at the same time, our nurse practitioners, who are thoracic medical oncology nurse practitioners, many of them were actually pulled into the hospital's efforts to screen patients for COVID-19 and to manage these patients. So really a testament to how strong they are with their patient management and their flexibility. So by late March, it also became clear that the hospital was really going to need to increase its staffing of inpatient floors. So typically, of course, our medicine floors are staffed by residents, fellows, and hospitalists. But at this point, by the end of March, it was clear that they needed to really ramp up staffing a lot more than that. So around that time, there were a number of floors within the hospital that were converted from surgical floors or other specialties to COVID medicine floors. And the oncology, the division of hematology oncology took one of those floors to staff it entirely with hem-onc docs. So the floor that I was on was actually a medicine floor, but previously it had been the urology and ortho floor. So also big shout out to the nurses on that floor who were very, very flexible and quickly went from being ortho urology nurses to now COVID medicine nurses with a day's notice. So the staffing model was that we pulled in 4 medical oncologists and 2 fellows to staff at any given time. Excuse me, 3 medical oncologists and 2 fellows. So 5 during the day and then 2 people at night. And we took 12-hour rotating shifts. We were assigned 4 to 8 days per month. And I did that for 8 days in April, and I just finished 4 days in May, and I'm looking forward to probably going back to some more days later in May and in June. So I can talk a little bit more about the experience on that floor. You know, I think what's sort of most striking is that, of course, I'm trained as a medical oncologist. All I do is thoracic medical oncology, and all of a sudden I was put onto a medicine floor, acting as a hospitalist. So it was like being back to intern year, but I was my own attending and had my own list of patients. So my census was typically 5 to 7 patients at any given time, and there was a lot of turnover with people coming in and going out, admissions and discharges. I'll hit on sort of 3 main themes of the experience, and happy to talk about these in more detail if anyone wants. But the 3 main themes, I'd say, the number one is it was striking how sick patients can get with this disease. You know, I think we are used to recognizing certain patterns in medicine and responding to those, and this is a disease that we just don't have the training and the pattern recognition for when we start seeing these patients. So, you know, there's a learning curve in trying to get used to what are the signs of somebody who is going to get sick and getting sicker. You know, there are things like rising inflammatory markers and increasing oxygen requirement, but that can all change very, very quickly, more so than we would sort of typically have expected for other viral illnesses. So that was a learning curve, but I think something that we all got more familiar with the more days we were on service. The second theme is this is just a disease of so much sadness, and I think that you see that on so many levels. You know, the hospital is a weird sort of ghost town in a way, because there's nobody visiting, obviously. There's no visitors allowed into the hospital. And you just see staff walking through the halls, but then at the same time, there are these incredibly tragic events kind of unfolding in the patient rooms, where we see not only that patients are affected, but multiple family members are affected at the same time. So it was not at all uncommon that we had patients on the floor where multiple family members were also on our floor or in other parts of the hospital. We even had unbelievably tragic situations where patients were dealing with hearing the news of the death of a family member by phone when they are alone in the hospital and unable to be comforted by others and still coping with the reality of their own illness. So, I think that all of that was very, very moving and really hard, I think, on all of the staff to watch a lot of this unfold. Then the last theme that I will focus on is the support within the hospital. So I have to say, this whole restructuring of the hospital and putting an oncologist onto a medicine floor as a hospitalist would not have been possible without the unbelievable support that the Department of Medicine at MGH has provided. So there were a whole series of resources that kind of kept us going and supported us throughout this whole process. Number one, we were on with colleagues, and I have to say I was so grateful that I was on with my oncology colleagues, and in fact, with one of my very closest friends, Dr. Zosha Piotrowska, who's another thoracic oncologist who many of you probably know. We actually happened to be paired on the same 4-day block, and that camaraderie went a long way. We were residents together at the Brigham, so we were kind of joke that we were just reliving the old days. But it does make a big difference. Number two, the support from the Department of Medicine. So what they did was they actually paired hospitalists with our service, so that each day, we're putting in all of our notes in Epic and all the data's in Epic. There was always multiple people kind of overseeing what was happening with these patients from afar. Of course, people are not coming to the floor and seeing the patients because we're really minimizing our face-to-face interactions and preserving PPE. But every day we would get a call or an email from a hospitalist who said, hey, I looked over your list of patients. You may want to adjust the diabetes medicines in this way. You may want to adjust the blood pressure medicines. And that felt good to have all of that support behind us. In addition, infectious disease was also following all of these patients very closely. So we would get daily pages from the biothreats pager saying, you need to run another COVID test on this suspected COVID patient, or this person is actually close to being able to be ruled out. We saw some of that more recently with people who have had a previous COVID infection and are now starting to test negative with multiple tests. So that was very, very helpful because we weren't sort of left on our own to decide how we should be categorizing somebody as potentially COVID positive or not. And then one really nice service that was also included was a group of MDs pulled from around the hospital who are fluent in Spanish, who are also there to support us. So many of the patients admitted were Spanish speaking only, and this was really striking. And my Spanish is okay, but not great for goals of care conversations and the level of conversations that we really had to be having. And it's one thing to have an interpreter on a phone, but it's a whole nother thing to have an MD at your side who's able to help facilitate a conversation around what it may look like if you may need to be intubated, or trying to decide whether our discharge plan is safe. Should you be going home with family? Do you have a room where you can self-isolate in a safe way? Or do you need to explore one of our other discharge options? So that was tremendous to have those colleagues at our side to be able to help with those discussions. And then finally, the last thing I'll just touch on is that it's been very interesting to see kind of the evolution of the types of patients that we're seeing from early April now to mid-May. So in early April, pretty much everybody on the floor was either a COVID rule out or a newly diagnosed COVID patient. And you could really see kind of the early stages of the disease and how the disease was manifesting in the first couple weeks of infection. Now what we're seeing some of those still, but we're also seeing patients who had COVID diagnosed 6 weeks ago, long ICU stay, and now they're coming out of the ICU and back onto the medicine floor, and we're dealing with the complexities of the medical management in these post-ICU patients, some of whom have trachs, some of whom have a very slow process to wean off of the sedation from the ICU. So that complexity is different than what we had seen up front. So I'll stop there, and I'm happy to take questions about that experience.
Anna, that sounds amazing and sounds like you had incredible support. Thank you for sharing that experience. Could you tell us about your testing capabilities? At Penn, we've had several different levels of testing. There's some tests that we can order for certain individuals that come back relatively quickly. And then we have our regular test with a 24-hour, 1 to 2 day turnaround. Were all of these patients getting tested in the ED or outpatient and then getting admitted, or did you also have COVID rule outs on your service?
So we had both. Initially, when I started, the turnover time for the COVID test was a little bit longer. I think it was initially a few days, and then it's gone down. It's now about 6 hours, but we are primarily using nasopharyngeal swab with RT-PCR as the testing method. That can be done in the outpatient setting. We have now a whole system of respiratory illness clinics, these RIC clinics that are designed to take patients who are possible COVID patients and do testing in the outpatient setting. The ED, of course, has the testing capability on site. And now, in fact, our emergency department is testing every single patient who comes in, whether they come in with symptoms of COVID or not. And what's striking, actually, is that now we're seeing patients admitted to the COVID floor who are COVID positive, but actually have no symptoms whatsoever of COVID and are there with something completely unrelated, like a new bowel obstruction or some other medical issue. And then on the floor, we also do testing sometimes. So we have what we call the designation for a patient who's under investigation for COVID is a PUI, patient under investigation. So for those patients, we have the ability to test them on the floor. But a single test, a single negative test does not rule out COVID, let's say. So usually we're doing multiple tests. Again, the infectious disease team is looking very carefully at all the characteristics of these patients to decide, is one test enough? Is two tests enough? Do they need three? Even after 3 negative tests, are we still suspicious enough that we're going to keep their PUI status and not remove that flag? So there's a lot of layers to that infectious disease is involved with closely.
I'd like to talk about, obviously you've been displaced from your usual routine in that is normally treating patients with lung cancer. And it sounds like a lot of other people are as well. And it's more of a skeleton crew doing lung cancer treatment. How's that going? Are a lot of patients having their treatments deferred, their visits with much longer intervals? How are patients coping with this change themselves? Do they feel like they've been kind of marginalized, or are they okay with it? And how much are you using telemedicine for managing patients?
Yeah, so I think we, like many practices, really as soon as the COVID crisis started to clearly unfold in our area, we started very quickly minimizing the number of patient visits into our clinic. So for example, patients who are long-term responders to immune checkpoint inhibitors, who really have had no evidence of progression for a year or longer, those are people who typically I would feel comfortable pressing the pause button for 6 weeks and saying, let's come back to this. Now, what's interesting is that in March, we thought that the pause button would last 6 to 8 weeks, and now here we are, and there's no end in sight. So now we're starting to deal with kind of how to reintroduce those patients, but at least now we have better systems in place with the clinic with how to manage people in the setting of COVID. So there is some of that, some sort of ramp down in the clinic, but at the same time, I mentioned that I was on for 4 to 8 days out of the month. So in the rest of the time, you're right, I'm still a thoracic medical oncologist. So doing a lot of telemedicine with my patients. Again, our group had 1 MD and 1 NP on site each day. So typically on my weeks that I was not on service, I would be in the clinic one day seeing the patients of mine who needed to come in person, and then also covering whoever else needed to come in for other doctors' patients in the clinic that day. I think patients were very, very understanding. In fact, I think most of my patients sort of had some relief when we started to have the conversation of, should we really bring you in or not, or should we pause your treatment? I think most people really didn't want to come in the setting of COVID, and felt relieved that we were also taking that into account. And I think they also equally feel relieved that now, as we're starting to bring them back to clinic, we really have very good systems in place for screening patients appropriately and triaging patients appropriately. So we feel like it's a very safe environment, and I think that's the most important thing. On a personal level, I can say that I've been just incredibly touched that most of my patients, when I talk to them and say, I'm sorry, next week it may be another doctor speaking to you rather than me, or another doctor you see in clinic, they say, oh, Dr. Farrago, I hope you're okay, please stay safe. And that means a lot. They're really much more concerned with our safety, after everything that they see on the news, than they are with, if they have to see one of my other colleagues one day when I'm on service.
That's heartening.
And Anna, thanks for those comments. And I just want to explore a little bit more of what you were saying. So all of us were in the same boat a couple months ago, where we're scouring our schedules to try to find ways to keep patients from coming in. And the message that they're at risk and they need to stay home and they need to do that has really gotten in. And I'm still getting messages from patients saying, "Oh my gosh, I need to put my visits off." But we've already been putting them off for a couple months, and we work in a kind of cancer that months matter for a lot of these patients. And I think they still have the message that they're really at high risk. And that's true for clinical care. That's true for clinical research. Clinical research is shut down in a lot of different places, or at least slowed down. Mm-hmm. Now that we're getting in some places it's getting better, but in a lot of places it's just kind of leveled off, and it's going to be like this for a while. How are we going to message to patients to get them back and safely resuming treatment? Because I don't know about MGH, but our numbers have dropped precipitously in terms of visits and follow-ups and new patients both.
Yeah, I absolutely agree. So our numbers have dropped tremendously too, and I'm scared. I don't know where the new patients are, and they're not coming into clinic as much as they typically would be. So I'm concerned that there are patients who are putting off symptoms rather than coming in for initial presentation. And then of course our existing patients, we experience the same thing, that they have concerns about coming in the setting of this crisis. What I can say is that I try to reassure them to say that we as a group and as a cancer center and as a hospital have really learned a lot about this disease in the past 2 months, and have built up a tremendous infrastructure for managing and triaging people appropriately. So, we have separate clinics for patients who are either suspected COVID or known COVID or prior, COVID exposure, and can really keep them separate from everyone else who is coming into clinic who has no symptoms or history of COVID. We also, are continuing to, unfortunately, but I think for safety reasons, limit visitors. Everyone also wears a mask. Everyone gets screened with a whole list of questions beforehand about possible symptoms, and then temperature gets checked multiple times over the course of the day when they're here with us. So I do think that we now have the infrastructure to take care of these patients. And exactly as you said, we need to do so. This is a disease that typically moves quickly, and further delaying things longer than we think is reasonably safe, I think, is not in patients' best interest.
Yep. Anna, you've been talking about how you've modified clinical care and delivering that from a clinical perspective. I'd also love to hear about your role as a translational researcher. We rely on collaborators and colleagues like you from Mass General to really help push those preclinical and translational advances in the wet lab, animal models. Can you talk a little bit about how the COVID pandemic has maybe put some of those things on hold, and what kind of impact are we looking at in the years to come?
Yeah, that's a great question. So, we agree that at MGH, we really see ourselves as leaders in translational research. And a lot of that is based on having a tremendous infrastructure of tissue collection at the time of biopsy and other efforts to link our clinical care with ongoing research efforts in the lab. And we certainly, again, patient safety is the most important priority for us. So as soon as this pandemic really started to unfold in the Boston area, all of our research tissue collections went on hold. And that's for multiple reasons. We don't want our research assistants in the hospital if they don't need to be in there. And we don't want people in the lab on that side of things working if they really don't need to be there. So it is a loss from the standpoint of the translational research, but I think it was a necessary step. We're hoping that and we expect that over the next several weeks to month or two, we'll be ramping that back up and be able to start to collect those very crucial research specimens again. We are still doing patient biopsies when they are needed for clinical purposes. So certainly anybody with a suspected new diagnosis is still getting a biopsy. Patients who have progression on a prior tyrosine kinase inhibitor, and we are trying to assess for mechanisms of resistance, those are still certainly clinically indicated, but we're just not collecting research specimens along with those biopsies. We have, as you know, we sometimes have clinical trials that require a research biopsy to be performed. And those typically we have not been doing. So, with the guidance of our IRB from the Dana-Farber Harvard Cancer Center, we have not been doing biopsies that are not required for clinical management.
So Anna, there is some concern that perhaps small cell lung cancer as opposed to non-small cell lung cancer patients affected with COVID may be sicker and the mortality may be higher. We don't quite have direct evidence just yet, but in your experience in taking care of a large group of patients, presumably some of your cancer patients were infected with COVID too. Have you seen these differences? Are your small cell patients sicker?
Too small right now to really say for sure. I think it's very reasonable that that's a concern. As you know, most of the regimens that we use for small cell lung cancer are cytotoxic regimens, and we think that those being immune suppressive can certainly increase the risk of infection or complications from infection with COVID-19. We also know that unfortunately, small cell lung cancer tends to go hand in hand with a history of smoking. So those may be patients who also have underlying emphysema, cardiovascular disease, diabetes, and those cardiovascular illnesses are also significant risk factors for more severe COVID. So I think these two things are closely intermixed. Again, whether we clearly see a difference between outcomes of non-small cell and small cell yet, I think it's a little bit too early to say, but I wouldn't be surprised if ultimately there is, unfortunately, worse outcomes for patients with small cell than with non-small cell. We'll have to see.
Just broadening and turning then to non-small cell or lung cancer in general, what have you and Mass General in general, as a general concept, been doing differently? Are patients getting surgeries now, or are all the beds and vents being taken up by COVID, or at least reserved for people with COVID-19? Have you changed any radiation approaches, seen and been wary of associations of certain medications with unfavorable outcomes or higher risk of complications that have changed your day-to-day management?
The answer to the first part of the question is that certainly surgeries and probably even some radiation has been affected by COVID. I think much like the decisions that we make as medical oncologists, where we're carefully weighing, is this something that we can safely delay for 6 weeks or not? I think the same types of calculations have been made for the surgeons and the radiation oncologists. We have again, a very, very collaborative, close relationship with our surgeons and our radiation oncologists. We have a multidisciplinary meeting with them each week. So we actually turned part of that meeting, when all this started, we turned it into kind of a case review portion of the meeting, where we pulled in cases where one of the practitioners from any of those specialties sort of had a question: what do you guys think about what I should do in this case? Do we feel comfortable delaying? Do you think I should push to try to get this person into the OR now? The surgeons have been able to operate through this process, but definitely on a much reduced volume. So I think, I don't know how many operating rooms they normally have, but they certainly had much fewer smaller operating room space than they had previously had in the schedule. And I think similarly, the radiation oncologists, they've been treating patients, but can be reasonably delayed or not. So as you know, for example, sometimes we have non-small cell lung cancer patients with multifocal disease and very slowly progressive nodules, and there may be one that's starting to become a little bit more solid than ground glass, and we're keeping an eye on it, and at some point we want to SBRT it. Is that something we need to do now, or is that something we can wait a few months on? I think those are the types of decisions that we're making, but no one feels comfortable making those decisions alone. They're not easy decisions to make. So again, I feel very lucky to be among a group of colleagues where we've all worked very collaboratively, because certainly it feels much better to make that decision knowing that everyone else agrees rather than trying to make it on our own. And then in terms of medicines, you asked about, are there medicines that we're avoiding because of potential interaction or risk with COVID-19? Not specifically, other than I think that, again, we're all wary of the effects of cytotoxic chemotherapy in this setting.
And actually, following up on that a little bit, earlier on you'd mentioned that, for example, all patients coming in through the ED are being tested for COVID. In the outpatient setting, as we look forward to trying to live with this for a while, how are you going to be incorporating testing into your patient care? You know, for lung cancer patients, are we going to start testing everyone before they get chemo or before they embark on 6 weeks of chemoradiation, testing people before surgeries and bronchs, and people who are infected? Should we use testing to tell when it's safe to start their treatment? What are your thoughts?
That's a great question. I think it's something the hospital is really grappling with on a high level. So I don't think it'll be as much an individual decision about when we should be making those calls as it'll come from higher up. So I don't know that we have a clear plan for that yet, but my guess is that we're kind of moving in that direction to some extent. I mean, we've already seen that in our emergency department, that now we're testing every single patient who walks in rather than just those patients with COVID symptoms. And, you know, I anticipate that we'll see some of that in the outpatient setting. As you all know, lung cancer is a disease that commonly presents with symptoms of shortness of breath, cough, and so it can be very, very difficult to distinguish those symptoms from possible symptoms of COVID-19. So I'd say we have a very low threshold to send patients to our RIC, that respiratory illness center or clinic, for evaluation, and we can get patients in very quickly. We kind of have a direct line in there that we can set them up with a visit same day or the next day, and then get a result back very quickly. So although we aren't yet testing everyone across the board, we have the ability to very quickly and efficiently test pretty much whoever we need to test at this point.
You know, you're describing your day-to-day is so radically different, and your clinical operations as a unit are so different now than they were 6 months ago. Those changes that you've made, which of those do you think are going to be permanent as we sort of move into this sort of longer phase?
Yeah, you know, I think there is some silver lining to this whole thing. And one is that we have very quickly learned how to integrate telemedicine into our practice. And I'm sure this is true at many other institutions as well. But now, you know, most of my patient interactions are actually telemedicine interactions rather than in-person interactions. So I do a lot now by telemedicine. Certainly scan reviews I do by telemedicine. Periodic check-ins for patients who are on a oral tyrosine kinase inhibitor. We can get labs in the outpatient setting and then do a telemedicine visit to check on symptoms and do that as the clinical follow-up. So I think in some ways that actually is very, very helpful. There are plenty of patients who we see who come from long distances, who don't like fighting traffic in Boston, although the traffic is pretty minimal these days. But who really appreciate doing a telemedicine visit. I've done a few new patient visits by telemedicine. It's different. I don't love it, but it's certainly great to be able to offer that to patients rather than having them really have no way of interacting with the team. And the other sort of nice thing about the telemedicine is that we always try to do a multidisciplinary visit and bring in the surgeon and the radiation oncologist at the same time, but sometimes that's hard to do if somebody's off site at another clinic. Now it's really very easy to do. So I've done several new patient visits where we have a Zoom call with the surgeon and the radiation oncologist and the medical oncologist all on the line with the patient, and the patient's daughter who's in another state is also calling in. So it's nice to be able to do that all together and actually see each other rather than doing phone calls.
Can I ask just about, obviously in Boston, you've got other states right nearby. You have patients regularly coming from New Hampshire or various other parts of New England. Do you run into stumbles with telemedicine because of licensing problems now?
That was an issue at one point, but is now no longer an issue. So that, I'll be honest, is sort of above my head in terms of hospital administration and how those things are sorted out. But at this point now, we are able to see and evaluate patients both for new patient visits and for follow-up visits, regardless of which state they're coming from. But it was initially an issue where for a brief amount of time, we weren't able to see new patients from out of state. And so we had to sort of emergency credential a couple people within our group to be able to see patients from New Hampshire, Maine, and Rhode Island, Connecticut. But within a week after that, that issue got resolved.
Okay.
So, now that we're in this pandemic over the past couple of months, some questions that are now plaguing us are, when to begin treatment for these COVID positive patients. Earlier we could all agree that if somebody is testing positive for COVID, we would hold treatment, at least their systemic therapy, be it chemotherapy or immunotherapy, perhaps, consider holding TKI in case of symptoms, although there were, no clear guidelines for either scenario. But I think all of us sort of felt comfortable that if patients were symptomatic, we would hold treatment. But now that, all of us have perhaps treated these patients, and this question is not just for Anna, but for everyone else, are you using antibody testing as sort of a measure to test for immune levels or immunity before beginning therapy? What's your practice been?
So I think this is also probably quickly evolving. We do have antibody testing available, and we actually have testing that has been developed in-house by John Iafredi, who's our amazing molecular cancer pathologist, but now is very quickly transitioned into our molecular COVID-19 pathologist, who's really come up with some fantastic assays for doing antibody testing. So it is available to us, but we haven't quite yet really integrated that into our practice. I think we will be very soon, and it's a good question. Should we be using that to decide when it's safe to give an immunosuppressive chemotherapy? I can say, it's really tough. My experience on the inpatient ward was very educational, because it really showed me that we can see such a range with this illness. So just because somebody tests positive, doesn't necessarily mean that they're sick. I had patients up into their 90s who presented with, a syncopal episode that probably actually wasn't even related to COVID-19 and happened to test positive, but really didn't have any of the other clinical symptoms of COVID and none of the elevated inflammatory markers. So even though we can detect the virus, that alone isn't necessarily predictive of how sick they're going to become from the disease, and whether chemotherapy is going to impact that or not. We suspect that it may, but I don't know that we really know that for certain yet. So I think it's hard to make those decisions, and I think they really have to be made on a very much a case-by-case basis, with some clinical judgment about the risk-benefit balance for that particular individual.
At Georgetown, we're doing a large investigation into seroconversion rates for healthcare workers and for patients. But we're very quick to point out for people that are involved in the study that when you get that result and it shows that antibody level, we don't know what that means. We don't know if these antibodies are protective. We don't know how long they last. And so if you're antibody positive today, it doesn't mean that a month from now, 3 months from now, you're not vulnerable to reinfection. And we really just don't know that yet.
That's absolutely right. So.
Yeah, this is one of the biggest topics that comes up at all of our staff meetings. We always have the head of our pathology department there answering questions about antibody testing. And the clinic's position so far has been that, none of the tests really are sufficiently reliable, to know what to do with that information. They haven't really made that broadly available to us yet, even though I think that's probably the number one thing that everyone's curious about and wanting to be able to look to see. I would love to know if I've had the virus or immune to it. But of course, if I did the test, I wouldn't know if I was immune just because I might have a positive or a negative test. So I think that'll be over the next month, probably a lot more news about that.
Can I get a sense of how people, just wherever you are, the temperature of adherence to mask wearing and social distancing? Because I think it's very geographically variable. Anna, you mentioned that traffic isn't what it was. I think we're all in places, many of us are in places where traffic has has gone from being one of the most maddening aspects of city life to much less of a factor. But I was recently just out with my wife walking around some of the beaches of California that are suddenly much easier to drive to, wearing a mask, but frankly shocked by how many people were not. And I just wonder how much people are outliving their lives and feeling kind of pandemic fatigue and just not adhering anymore, and how concerned we should be that this is going to lead to a plateau that is going to be very difficult to push down in terms of dealing with this for a very long period of time. Any thoughts from where you all are?
I think it's very regional. There are definitely parts of even Philadelphia, that practice social distancing really well, and everyone's masked, and then you drive 10 miles in either direction, and the landscape changes. So I do think it's very regional, but thankfully, the hospitals are still very strict about it, and we're still enforcing obviously the no visitor policy as much as we can. So trying to do our best.
But Jack, this is one of our greatest concerns. We're sitting here with bated breath as our numbers have been sort of steady, but as Maryland and Virginia, at least in my area, lift their stay-at-home orders and start to reopen slowly, are we going to see that second wave that we're really seeing from China, from Korea, where maybe we can have that second part of the pandemic that may be even more severe?
Yeah.
Yeah, no, absolutely. I think it's important to remember that this has always just been a subset of people who've been social distancing here. I think most of the models that I've seen have been assuming that somewhere between 40 and 60%, even in states that have stay-at-home orders, have been social distancing and staying locked down. And a lot of people are moving around. And as these things are changing, there was a nice map of cell phone data showing that a lot of the states, like Michigan, for example, have had dramatic increases in moving around as some of these orders are released, or people are just starting to kind of, as you say, get fatigued and move around more themselves. I mean, even here in Cleveland, where they're starting to release some of the orders, retail's opening some of our outdoor restaurants. You can actually go to a restaurant as long as it's got an outdoor patio and are socially 6 feet away from other tables. But Ohio, I think, been a really good model for successful public health messaging and social distancing. But even waiting to cross the street to go into the hospital, about half of the people who work in the hospital are wearing the masks, and about half the people have them in their pockets and just put them on before they walk in because they have to have them on when they go in. So it's always going to be a mix.
Yeah.
You can say that in Massachusetts, there's now a law that you have to be wearing a mask if you are not able to safely social distance. And, I think that hopefully that's helpful. I can say my personal perspective is pretty limited to my neighborhood in my suburb of Boston and the walk from the parking lot into MGH. But I think, from what I see, people are following that pretty well. But I do think that there are other areas where it's much harder to social distance, and even though some people are wearing masks, others really are very resistant, and I think that is a huge challenge. And as we think about how our hospital has so quickly ramped up to meet the needs of the patient population with COVID-19, and now we're sort of starting to ramp down a little bit, the question of how we're going to have to accommodate the flux of the infection as it changes over time. Are we going to have to ramp back up and back down again and again? I think we just don't know, and I think that's a major challenge.
Thank you so much. I would really love for us to just quickly go on and focus on some cases that I know you all have available to discuss. So can we get into those?
Yeah, I had a case that I'd love to get your opinion on. It's one I'm dealing with right now. One of my patients, a very dear patient of mine, 62 years old. She has a metastatic lung cancer, EGFR, exon 19 deletion, and she's been on multiple lines of therapy, TKI-based, eventually now moving on to chemotherapy. We had her on carboplatin, paclitaxel, bevacizumab, atezolizumab. a great response. She's doing very well. She's been on maintenance bevacizumab and atezolizumab now for about 4 months, tolerating it very well. She noticed about a week after her last infusion that her son was getting ill and febrile. Unfortunately, he did become positive, was hospitalized. About a week later, she also developed fever, became relatively ill, was tested and was COVID-19 positive. Now, fortunately, she was not hospitalized. She recovered at home. We were following her very closely. She is now feeling 100% fully recovered. My question to you guys is when should I restart the bev-atezo maintenance? You know?
So you said she wasn't very symptomatic, Stephen. Was she admitted to the hospital? Did she develop any respiratory complications?
So she was pretty symptomatic. So after her son fell ill, about a week later, she developed fevers and she felt very sick. I was really on the border of bringing her into the hospital, but we just called her daily, and she turned around. Fevers went away. The fatigue and malaise really lingered for a few weeks, and we did skip 1 dose of maintenance treatment. And now she has no symptoms. Now she's fully recovered. She's anxious about this lung cancer that she's always been right on time every 3 weeks, never missed a day. We've skipped 1 dose. She was due for her maintenance therapy. The second one we would have missed would have been yesterday. And so we've now skipped 2 doses of maintenance therapy. And I'm watching. She feels well. I'm not sure. Should I retest her? Is there any value to that? Should I continue to watch?
Stephen, I don't think there's necessarily revalue to retesting. I don't think whether it's positive or negative actually at this point should impact your decision making. It will impact how you triage her through clinic potentially. So that's a reason to test, but not for the decision making about treatment. It sounds like she's approximately 5 weeks out from the onset of her symptoms. She's symptomatically improved significantly and nearly resolved. It sounds like I would feel comfortable restarting her.
Yeah, I mean, I agree. I think given that she's recovered, and the other thing to remember about these medicines is she probably was never not treated with these medicines because they have such a long half-life. And so it may be a little bit different if she was on combination cytotoxic chemotherapy, where you would be getting sort of an acute hit to the immune system after treatment. But for something like immune checkpoint inhibitor or bevacizumab that has a half-life in weeks to months, her blood levels have probably dropped, but she was probably, had it in her system the entire time she was ill. And now I would agree that I think I'd probably get her started again. This is someone who, as you said, probably is doing very well. And this wouldn't be someone that I would just give a break if she was tolerating it well.
And I think all the data that we know so far is really coming from across on patients that do poorly on cytotoxic chemotherapy, right? I mean, the French experience shows that patients with heme malignancies do worse because they receive myelosuppressive chemotherapy. And, there is no clear correlation, at least just now, saying that immunotherapy or perhaps these anti-angiogenic agents predispose you to worse outcomes. I would feel comfortable treating her, especially since you're not treating her with a cytotoxic regimen, and perhaps you're minimizing risk that way. But sounds like she's really stable and can withstand this. And sounds like she's very reliable too.
Well, obviously, there's no good data to speak to this, but I think that, as Nate points out, the fact is that these have very long half-lives, so she's never really been that off. That should even be kind of comforting that she's been through this with these online, and she didn't have a total cold turkey break from this. So I think sometime between now and the coming weeks is a good time to reinitiate it, and just understand that there's no absolute best answer here. We all have to go with a certain element of judgment.
Well, let me change it a little and see how your answer changes. What if we were just at the beginning of treatment? We had started her on osimertinib, and now suddenly she's very ill, symptomatic, COVID positive. I think all of us agree that in the midst of symptomatic infection, we would probably hold treatment. As she starts to recover, sort of when would we reintroduce targeted therapy?
I think that's a very difficult call, and certainly, I think it's something that we're going to all have to approach on a case-by-case basis. How sick is she from her cancer? Are you managing active brain metastases with the osimertinib and keeping those under control, or are you managing a very small asymptomatic disease burden where you have some flexibility to hold the drug for some amount of time? I think certainly there's a concern of the risk of pneumonitis with tyrosine kinase inhibitors, and then potentially exacerbating the respiratory complications of COVID-19. Hard to say if that's really ultimately we're going to see that pan out as a real problem or not, but it's a theoretical concern. But I think that with all of these decisions, you're really carefully weighing the risk benefit for each individual patient.
And you can anticipate that whenever you restart, there's a very high probability that response will kick right back in. So, I think that as Anna said, I mean, if someone has a lower tumor burden and not symptomatic, I think you could drag your feet on that and just modulate whether you think the risk of the interaction is greater than the risk of the disease progressing without being able to jump in and effectively reverse it. I think we're usually pretty confident that if the cancer hasn't really developed acquired resistance, it's very likely that we're going to be able to reintroduce and get another great response.
But the flip side of that, though, is if they had a high disease burden or if they developed symptoms that looked like the cancer was progressing, I would feel pretty comfortable getting, especially a tyrosine kinase inhibitor started again. I've certainly, over the years, had many people on tyrosine kinase inhibitors who held them for surgeries or admissions or, unrelated problems that, I usually don't feel too uncomfortable for relatively short periods of time. But once it stretches into weeks, then, I start to worry that they may end up progressing and getting sicker. So just keeping a close eye on that.
Thank you so much. Now let's head into our Q&A discussion. So we will open up the question and answer portion of this webinar. If you go to the Ask Question and Answer box on the right corner of your screen, you can type your question directly in the space that is in the box and then hit submit. So we did have a few come in, and we'll try and get through as many as we can with the time we have left. So this is actually a question that just came in from one of the cases you discussed, Dr. Liu. So the question is, if we use Dr. Stephen Liu's case, what would the panel advise if the patient is still on chemotherapy plus IO plus bevacizumab?
Yeah, I think the question obviously becomes a little more difficult when we introduce cytotoxic chemotherapy, as we were discussing about, the potential risks and factors associated with worse outcomes, as we've seen on these international data. But again, I think circling back to our initial discussions about, a delay for lung cancer of a couple of months is certainly not something that we take lightly. So I think in the setting of having a really stable patient with minimal symptoms who seems to have recovered, I would have, again, a very reasonable risk-benefit discussion and potentially consider, in Stephen's case, to even initiate chemotherapy. Of course, I would feel more comfortable, proceeding with a non-chemotherapy approach. But if I had to, and the disease was progressing, or I had to come in because of the lung cancer diagnosis, I think we all would probably want to come back, understanding that this is lung cancer at the end of the day.
I think at the time of positivity, it makes sense to hold just so we can sort of see what the course is going to be. And we've all seen patients with COVID-19 now, and those patients can get ill very quickly. But also, if a few weeks pass, I think those people are less likely to do so. And so once you have positivity, symptoms start to fade, generally, those patients tend to do a little better. So I agree. If the situation calls for cytotoxic therapy and the lung cancer is really a threat to their health and their well-being, then we have to move forward.
And I haven't encountered this yet, but I've been reading a lot, and maybe Anna, you can comment since you've had more experience directly with COVID patients, but I have been reading that a lot of patients have sort of prolonged sequelae from their infections and take, a long time to recover if they had a significant pneumonia. So if you had a cancer patient who perhaps got better and their fevers went away and they've recovered and weeks have gone by, but they're still pretty short of breath, still coughing, hard to tease that out if that would impact people's willingness to restart chemotherapy in someone like that.
Yeah, I agree. That's tough. And I think, our challenge as thoracic medical oncologists is also to try to sort out, is this sequelae of a prior COVID-19 infection, or is this actually active cancer that's starting to progress now? And, there can be such an overlap of those curves of disease presentation. So I think that's something that can be really challenging to figure out how best to manage.
Another question that came in, how are new patients with cancer getting diagnostic workups during this time frame? What are you all seeing?
I think that I'll qualify this by saying we're in a location where there's very low penetrance of coronavirus or at least COVID-19 in our part of Los Angeles and directly involving folks at City of Hope. We were prepared to push out, and we have delayed certainly the cases of a ground glass opacity that has grown by maybe 1 millimeter or 2 if you squint at it and is a little more solid. But patients who are diagnosed with a new rapidly growing and symptomatic lung cancer or lung abnormality are getting that workup really as they would. So I would say that we really need to prioritize and not put off a lung cancer that is very clinically relevant and symptomatic. And so really there is not an appreciable delay, and patients are still getting their workups. I think like Nate had mentioned, we're not seeing as many of the second opinions, although I think very recently we're starting to, but over the last 6-8 weeks, there wasn't as much movement from other parts of the LA area or other parts of the state and beyond to come for a second opinion. But the primary management needs to go on and has been.
I would say that, we are doing all of our diagnostic biopsies as well as workups as indicated, as opposed to, as opposed to 2 months ago. I think what has changed is that we are testing everyone for, COVID-19 prior to any interventional procedure, not just bronchoscopies, but even for IR-guided biopsies, of course, for surgeries, which has been a change, I think, partly reflective of the amount of tests that we do have available now as opposed to 2 months ago, but also because we understand how asymptomatic people can be, and the prevalence of just these asymptomatic carriers is pretty high. So we have incorporated this universal testing 24 to 48 hours before any given procedure, which has helped.
One thing that I've really taken a lot more advantage of over the past month or so has been mobile phlebotomy for ctDNA analysis. And while it's a little tougher to get repeat biopsies, liquid biopsies have evolved to the point where we're really regularly incorporating those. And now that a lot of the commercial companies are doing mobile phlebotomy, where the phlebotomist comes to the home, they draw the ctDNA analysis, send it off, we get the results in a week. That's really made things a lot easier for us.
I'm going to try and get one last one in here. So how are you monitoring for progression on therapies? Do you have access to CT as needed? And are you leaning more on molecular testing?
We certainly have access to CT and molecular testing as needed. We also, like it sounds like the other sites are doing biopsies as they're clinically needed. We're doing a lot of ctDNA testing if that is appropriate as an alternative to a biopsy. But all of the diagnostic tests and active surveillance that we do for patients with known diagnosis of lung cancer is absolutely ongoing. We remain very, very vigilant as we take care of our patients and recognize that this is a disease that requires ongoing active management.
Yeah, and I would second that. Just the message to if there's patients watching and other people that the cancer centers in the United States are open for business. The patients have an abnormality that needs to be worked up, needs to be staged, needs to be biopsied, molecular testing needs to be done. Patients on treatment who need scans, we're still doing that the way we would always do it. We're only backing off where we think it's safe to do that, and when the judgment is that it's not going to impact that patient's care to delay.
What I found
And
myself.
I would just add that, counterintuitively, our ability to actually see patients virtually, right, and accommodate more patient visits has increased. So we're actually able to offer more remote opinions or second opinions pretty easily now.
I was just thinking in the last hour that, it's interesting that one of the least kind of capitalized on findings is Dr. Ethan Bash's work out of Memorial Sloan Kettering and also I believe UNC, that that when they did a web-based communication with folks who are on active treatment for advanced cancer and constantly asked them about any changes in their symptoms, that improvement in communication led to more attentive adjustments in treatment. They were on treatment longer and had a 5-month improvement in median overall survival, which is amazing. And my concern is that we don't want to go in the other direction by pruning our communication so much by people not coming in that it leads to people not being able to stay on treatments or run into other issues, run aground and have worse outcomes due to fear of exposure to COVID by not, and not seeing us, not getting their scans, et cetera.
Absolutely. All right, well, that does appear to be all the time that we have for questions. Again, a huge thank you to the faculty tonight, Dr. West, Dr. Pennell, Dr. Liu, Dr. Aggarwal, and Dr. Farago, for taking the time out of their very busy schedules to virtually sit down with Enclave and discuss these very important subject matters with our audience this evening. Thank you also to our listeners, and I truly hope that you were able to gain some valuable insight into the clinical practice and how it's changing in oncology during the COVID-19 pandemic. So again, just as a reminder, you will be able to listen back and watch this webinar again shortly. Our next program is scheduled for May 28th at 8 p.m. And you can continue to visit enclave.com, sign up for our e-newsletters, or follow us on social media on Twitter, LinkedIn, and Facebook to get updates on when we'll be broadcasting more of these webinars. For all of your oncology news, please visit enclave.com, where you can also find our COVID-19 Resource Center. So that concludes this evening's webcast. Thank you and have a great night.